This is a station 5 case. Any one of our doctors interested to start the case, he can send me on a message. Yes, doctors. Any doctor interested to start the case, we can start. It will be a station 5 case.
Khalid, I can take.
Okay, who is talking? Dr. Home, Dr. Imran?
Dr. Imran.
Okay, Dr. Imran. Awesome. Dr. Imran, you can unmute yourself, please.
Unmuted.
Okay. Okay. Sorry. So this is Miss Rita Kohn, 51-year-old lady, came with sweating. Please see and examine. Doctor, you have 2 minutes to prepare yourself.
Okay, sure.
The case on the board, doctors, if you want to think about it.
Yes, Dr. Khalid.
Okay. Go on, doctor.
Okay. Good evening.
Good evening.
I'm Dr. Imran, senior house officer in the medical ward, and I received one letter from your GP that you are complaining of excessive sweating. Can I know briefly more about your complaint?
Yes, doctor. For the last 1.5 months, I start to feel much more sweating than usual. Despite we are in the cold weather, but still I'm sweating more and more. I don't know what's going wrong with me.
So this is for the first time?
Yes, for the first time, doctor.
Okay, I really sorry for this. Can I know that this started suddenly or gradually?
It didn't start suddenly, but I felt it. One
You
week
felt it.
I started to feel that I'm sweating more and more, despite it can happen while I'm sitting down without any effort.
Okay, got my message. Can I know where exactly you are having this sweating more over your hands, over your face, or all over your body?
As, more in my face, but less on my hands.
Less on your face, more on your face. Okay. Do you have any feelings of hotness or coldness over your face at the
Yes,
same time?
yes. Sometimes I feel more hot.
Sometimes you feel more hot. Okay. Anything that aggravates this sweating, any physical activity or any emotional stress or anything else
No,
like
no,
this?
doctor. No, nothing at all.
Okay, nothing at all. Can I know? I will ask you some personal questions. Still, you have your periods
It's intermittent for the last few months.
last few months. Yes. Okay. I mean, they are not regular. Before they were regular.
Yes, because doctor, this is the age that
Hmm. Yes,
messes
I can
starts
understand.
to stop.
Okay.
Yes.
Okay. Then does this sweating is associated with the racing of your heartbeat?
No, no racing of my heartbeats.
Okay. Do you have any chronic illness like diabetes?
Diabetes, yes. I'm having
Uh,
diabetes for the last 10 years. Yes,
okay.
10 years, yes.
And you are taking medicines for that?
Yes, I'm taking just metformin. It works well with me with some exercises.
Did you check your blood sugar while you were having sweating at the same time, at that time exactly?
Um, I didn't check, doctor. I didn't check.
Were you feeling uh, any feelings of hunger or abdomen cramps in your belly, in your tummy at that time
No,
when you had?
I didn't feel like this.
Hmm, okay. Um, do you have any high blood pressure?
No, doctor, I don't have. My blood pressure is well controlled.
It is controlled. Okay. Um, do you have any feeling of numbness or tingling in your hands or in your feet?
No, doctor, I don't feel like this. I'm well. Just this sweating annoying me so much.
And okay, okay. Uh, do you have any sort of dizziness while standing up from your sitting position?
No, no, I'm well. As regard this point, I don't feel like this.
Okay. Sorry, I'm asking you this question, but I usually ask this question to all my patients. Do you use any illicit drugs?
No, doctor, I'm a very conservative person.
Yes, I can understand. I appreciate this. Okay. May I examine you?
Yes, doctor, for sure.
Okay. Uh, I would like to see, I will start from her hands. Okay. And I will
Oh,
feel her hands. Are
okay.
they sweaty? Are they cold?
No, no,
I
little
will
bit
check her
sweaty.
pulse. A little
Pulse
bit
is
sweaty, but not.
78 beats per minute and regular.
Okay. I will check for the tremors, fine tremors in her hands. I will outstretch your hands and
Yes, no tremors, doctor.
no tremors at all. Okay. I will check her blood pressure.
Blood pressure is 130 over 75.
Okay. May I ask you, do you have any lumps and bumps in your body anywhere?
No, doctor. I don't have.
Okay. I would like to check her lymph nodes in the cervical area, in the neck, in the axilla.
Okay.
Okay.
No lymph node enlargement, doctor.
No lymph node enlargement. May I ask you, do you have any temperature with this sweating? Did you take any fever at that time?
Fever? No, doctor. You know, it's for the last 1.5 months. I didn't feel fever at all. I feel this sweating. Sometimes I feel that I'm hot, yes, but during the sweating, I cannot correlate between fever and sweating.
Okay. I will check her abdomen. Any hepatosplenomegaly? Okay.
Splenomegaly? No splenomegaly.
Okay. I would ask you, are you using any oral contraceptive pills?
No, doctor. You know, my one minute remaining. You know, my period is irregular, and by the way, I'm not in a regular relationship, so I don't use them.
May I know your concern, please?
Yes, doctor, I'm concerned about this. I'm afraid because, you know, one of my friends, she had cancer and she was sweating so much and she deteriorated very rapidly. I'm afraid of this.
Okay, Ms. Rita, I highly appreciate your concern. The problem that I got from your history and from your clinical examination, I think the problem of this excessive sweating that you are having for last 1.5 months is because of your menstrual problem, your problem with your periods, and you are in age, in a period of age where the hormones in the body of females, they start to lose their balance, and for that reason you are having these excessive sweatings. For that, to diagnose it, we will do some
Time. Thank you, doctor. 2 minutes for discussion. What's your differential diagnosis, doctor?
Most likely, my first differential would be what to call this, at the end of the menses.
Perimenopausal syndrome.
Perimenopausal symptoms. Sorry, perimenopausal symptoms.
Okay, so she was concerned about cancer. Did you answer her concern and did you check for her cancer or weight loss
I didn't answer
symptoms?
for this. I should have. I asked for the lumps and bumps, by the way, but I didn't ask for this, and I should have replied for the concern.
Okay. She told you that she had diabetes for the last few months. Did you ask her about? Did she check her eyes? Did she check her kidneys? Did you ask her about this?
Actually, I asked her during the history that for how long you are having, and are you having any symptoms of neuropathy or autonomic neuropathy, and because of the time restraints, I would have examined for her eyes and for this, but she was not having any symptoms of autonomic neuropathy. So,
yeah, doctor. So, do you think that this patient is actually having cancer, or this is just a problem of her premenopausal symptoms?
we cannot rule it out. It can be one of the differential. Maybe she might be having some sort of lymphoma. So for that, we need to investigate.
Okay, thank you, doctor. Thank you, Dr. Imran, for sharing. Okay, so Dr. Imran, you did good, mashallah, but we have to, I will share it again, but we have to comment on the mistakes that happened in this scenario. After commenting and seeing and knowing the mind map for patients coming with sweating, because you know it's a silly case, but you know it's a very easy case if you reach it by a mind map. So before going to the mind map for sweating, number one, this patient having sweating, She's a 51-year-old lady, came with a sweating. Number one, and she's concerned about cancer. Number one, you should exclude the cancer by history. Night fever, night sweating, loss of weight, loss of appetite. Okay.
Yes, sure. I asked about the
Yes,
fever
doctors,
and
you can hear me well, yes? Okay. So, fever, sweating, loss of weight, loss of appetite. Did you ask here, doctor, about smoking history?
hello, Dr. Khalid.
Did you ask here about alcohol? What if this patient was a smoker and now she is having cancer in her lungs? You missed your patient, okay? So please, patient came with sweating, you should exclude this one. You should ask about smoking, very, very important. Number two, did you ask about her TB, cough, phlegm, okay? Any blood with her phlegm, so you should ask about this. You asked yes, do you have any lumps or bumps in her body? And she said no, and this is a good point. The fatal mistake that may make someone, not may, that it will make any physician lose the station if he did not ask about the drug history. Drug history is fundamental. Okay, imagine doctor, one patient came to you in your clinic, not on the basis, and you forget to ask him what the medications you are using. You know, in our life we will not do this. Usually we ask, not usually, always we ask patients about the drug history. You did not ask the patient about the drug history, and this is very important to ask any patient about drug history. So, in station 5, the issue is that you don't take detailed history like you take in the history station. Just focus the history, very focused history. Okay, one of the endocrinal disorders that can lead to sweating. Any doctor can write on the chat which endocrinal disorder. We have three endocrinal.
Hyperthyroidism and pheochromocytoma.
Yes, what else?
Hyperthyroidism.
Yes.
Cushing, carcinoid.
Carcinoid as well.
Very good, carcinoid. What else?
Acromegaly.
Acromegaly. Acromegaly.
Yes,
Very important. Acromegaly. Very important. Okay. Very important. So, these are the things. The good thing, you started to examine her thyroid, but you didn't complete. You offered just to examine the thyroid, and you know the thyroid gland in this station will be the only thing that you can examine, plus the lymph node. And the good thing, you examine the lymph node, and this is very good. Okay, but if you started, at least go very rapidly and examine the thyroid gland. We said yesterday in our station, doctor, please, can you mute yourself? Are you mute, you doctor? Okay, so please, doctor, as we said yesterday, if the examination of the thyroid gland goes like this. Upper limb, we said ETB 1 to 3. This is the examination of the thyroid gland. You know, in the first instance, you will tell the patient to just drink a cup of water and protrude his tongue outside. This is the first thing. Okay, then go to upper limb, ETB 1 to 3. What's ETB 1 to 3? E for thyroid acromegaly, T, two things in the T, which are the temperature and tremors, and the B for what, doctors? B for what? Three things in B.
Pulse.
Pulse, yes. What else?
Proximal myopathy.
Proximal myopathy. What else? Palmar erythema. Palmar erythema. No, palmar erythema usually. Okay, so this is in the upper limb. ETB 1 to 3. Then go to the eye. Examine the eye. How to examine the eye? As we said, cross and crescent. Cross, this will check for ophthalmoplegia. Crescent, you will put your finger in front of the patient and move it from above down in an arc manner to check for lead lag. Then Mobius sign. What's Mobius sign? Loss of convergence. Approximate your finger to the nose of the patient. If he is having hyperthyroidism, there will be loss of convergence plus exophthalmos. So this is in the eye. Then go to the thyroid gland itself. Inspection, palpation, percussion, auscultation from back. Then last thing in examining the thyroid gland is the lower limb. Here we said ETB, here we will say EDB. Whether A for thyroid acropathy, D for, any doctor remember D for what?
Myxedema?
No, not myxedema. The peritibial myxedema will come here. We took it yesterday Delayed ankle jerk, okay, in cases of hypothyroidism. And this is very important. You will find the hammer beside the patient. So you have to do check for delayed ankle jerk. If you don't know how to do delayed ankle jerk, please go to the YouTube and write delayed ankle jerk in hypothyroidism or hyperreflexia and hyperthyroidism. And the B4, proximal myopathy and peritibial myxedema. So this is how to examine the thyroid gland. Please, doctor, examine the thyroid gland on your partner, on your wife, on your son, on your daughter, on your friend, okay? So it will be easy. You can examine the thyroid gland within 1 minute, plus examining the lymph nodes, okay? Because it may be thyroid cancer, okay? So we will go now for the algorithm.
Excuse me, Dr. Khalid, one question, please.
Yes, yes.
If in history, during station 5, if in history you find out that this is the most probable cause and this is not the possible cause, because we had some differentials. I made one differential, patient could be having thyroid toxicosis, could be having autonomic neuropathy, or any hypoglycemic symptoms or anxiety. If we rule out all these differentials, should even then we examine for these things?
Yes, doctor, you should examine. Station 5 is an examination station. I will tell you something. They brought a case one time, patient came with depression, okay? And you asked about all things of depression, all causes of possible depression. And finally, the case was having postmenopausal symptoms, and depression was one of these symptoms, okay? But here you have to examine, for example, also the thyroid gland. You have to examine for the acromegaly if it is present, okay? So you have to offer to examine the most related thing. Patient came with weight gain and she is having depression. So think about, for example, hypothyroidism, okay? Or obstructive sleep apnea, or what you see it's relevant. And finally, if you didn't go to a diagnosis, you don't be ashamed. Tell the examiner, I couldn't find an exact diagnosis, but I am having a list of differential diagnoses, okay? So now patient came with sweating. What is the mind map for patient came with sweating? So ask him, is this night sweating or no? If it is night sweating, think about dangerous things. You know, nightmares comes at the night. So mares, big things comes at night. TB. HIV.
B symptoms of lymphoma.
Malignancy. Okay? Yes, doctors. Lymphoma or any malignancy generally. So TB, HIV, and malignancy. You should exclude them. And you can exclude them very rapidly. Night fever, night sweating, loss of weight, loss of appetite. Okay? Travel history, doctor, is very, very important in such a case. Patient is coming with sweating. Do you think that this patient may not be having malaria, for example? Okay, if you asked him, she may have told you that I was in a vacation in Tanzania and I didn't receive my anti-malarial medications well. Okay, so sweating, night sweating, think about disasters, TB, HIV, malignancy. How to exclude? Very rapidly: night fever, night sweating, loss of weight, loss of appetite, or any coughing of blood, okay? Any shortness of breath. HIV, how will you ask about HIV? I'm sorry to ask you this, but do you have any relationships, extramarital relationships if she is not married? Any shared needles or tattoo? Any blood transfusion? This is very important. And then malignancy, do you have any lumps or bumps at any area of your body? Then, so this is if the night is sweating. If the issue is not night sweating, if it is diaphoresis, I mean more and more. So doctor, why you don't think about ischemic heart disease? This patient is having diabetes for the last 10 days, and now she is having excessive sweat, and she is having sweating. Yes, this sweating is not related to her exertion, and this excludes the ischemic heart disease, but at least you should ask here, do you have any chest pain? Any racing of your heartbeats? Do you have any shortness of breath? So you have to ask about this. So night sweating, TB, HIV malignancy, diaphoresis, ask about ischemic heart disease. Come to the miscellaneous, which is a non-specific time, no specific character or no specific time for the sweating. Here comes hyper, hypo, and drugs. Hyper, hypo, and drugs or medications. Don't say drugs in the exam, by the way. Say medications. Drugs means addiction. So hyper, what are the hyper things that can lead to sweating? Any physician, any colleague can answer. It's okay, it's open. Hyper what?
Hyperventilation, hyperthyroidism.
Hyperthyroidism, yes. Hyperpituitarism,
Hyperventilation.
which is acromegaly, okay? We can bring it from above down. So start please with hyperpituitarism from above. Then hyperthyroidism, okay? Then go down a little bit. Hyperadrenal gland, which is called pheochromocytoma, as we know. Hyperplasia in a tissue. You know, carcinoid is a hyperplasia in the tissue. So four things can lead to sweating. Hyperpituitarism, which is acromegaly. So you'll ask the patient about what? What are the symptoms of the screening questions for acromegaly? What are them?
Any changes in the facial appearance?
Yes.
Any weight gain?
Yeah.
In ring or shoe size?
Any change in shoe size and ring size?
Yes, very good. Ring size, shoe size, any change in your facial character. Can I have do you have a previous photo? Can I have a look at it, please? Okay. Then you can ask about symptoms of hyperthyroidism, hot intolerance, flushing, racing of the heartbeats. Okay. Then ask about pheochromocytoma. What are the questions of pheochromocytoma?
Any episodic palpitation?
Palpitation, sweating, abdominal pain.
No, palpitation is a medical jargon.
Tummy pain.
Racing of the heart?
Yes. Racing of heartbeats, sweating, uncontrolled hypertension. These are the screening questions. If it is positive, then you have to dig deep and deep. Carcinoid. What are the symptoms of carcinoid?
Redness of the body.
With difficulty in breathing.
Three things: flushing,
increase,
diarrhea, bronchospasm. Yes. So the patient will have some shortness of breath, loose motion, and this redness of his and this flushing, plus for sure sweating. So flushing, diarrhea, bronchospasm, these are the triad of carcinoid. This is a very famous triad: flushing, diarrhea, bronchospasm. Okay. Carcinoid can come as a case of loose motion, by the way. Then hypo. We said hyper and then hypo. What are the hypo?
Hypoglycemia.
Hypoglycemia. Hypotension. Okay. Patient with hypotension. Patient with shock or hypotension can have sweating. Imagine that this patient is using antihypertensive medication or any other medication that lead to low blood pressure or diuretic for any reason, and her blood pressure is now going down. So for sure she may be having sweating. Don't miss drug history, please, doctor. So hypoglycemia, hypotension, and hypoestrogen, which is the case which come and hypoestrogen, which is menopause, okay? Because you know females at menopause, the estrogen goes down. Finally, drugs. What are the drugs that can cause sweating? We have 3 main drugs that can cause sweating: tricyclic antidepressant, robineol, and finally tamoxifen. Okay. So, which case we have here? Sorry, I forgot, you know, I forgot to write malaria here as well. Sorry, malaria. But to be honest, I don't know whether malaria causes only night sweating or sweating at any time. But don't forget to ask about malaria, because it's also an important cause. So, I will tell you how to deal with in such a case. Patient came to you with sweating. You will ask here about onset, course, duration, what increase, what decrease, associations, effective treatment, and date of last attack. If you couldn't get any data from this first line, if you couldn't get any data that will move you toward the diagnosis, then you will depend on, before reviewing the other system, till here, do you have any other symptom? She will tell you, what do you mean by other symptoms, doctor? Here, the job will be more hard, okay? But she can tell you, doctor, please, I am muting you. You are having so many voices in the background. Okay, so now at this time, you should ask here, do you have any other symptoms? She will tell you, no, doctor, I don't have any symptoms at all. I'm okay. Then you will start to dig very rapidly, asking about this. Any night fever, night sweating? No. Loss of weight? No. Loss of appetite? No. Please, doctor, when asking, don't ask 2 questions at the same time. So don't tell here, do you have any night fever, night sweating, loss of weight, loss of appetite? This is not acceptable. And don't tell here, do you have any night fever, night sweating? No. Just tell here, I will ask you rapid questions, yes and no. So please, if you can follow me, I will be thankful. So, do you have any night fever? No. Night sweating? No. Loss of weight? No. Loss of appetite? No. Do you have any shared needles? No. Blood transfusion? No. Tattooing? No. Any lumps or bumps at your body? No. Do you have any recent travel? No. Okay, then, do you have any chest pain, shortness of breath, racing of your heartbeats? No. Then come to the hypers. Do you feel any weather preference, hot, cold? She will tell you no. Do you have that your hands are very sweaty, racing of your heartbeats? No. Do you feel that there is any change in your shape, in the ring size, in the head size, in the shoe size? She will tell you no. Okay, so do you feel that, do you have high blood pressure? She will tell you yes, for example. So is it controlled? No, it's yes, doctor, it's well controlled. Okay, then do you have any loose motion or shortness of breath to exclude carcinoid? She will tell you no. Then you are going down to the hypos. You told me that you have diabetes. Doctor, please, when a person tells you in station 2 or station 5 or even station 4, if he told you that he is having diabetes, you have to ask about diabetes. You have to ask about everything in diabetes, which are, number 1, for how long you are
Duration.
having, sorry? Yes.
Control of diabetes.
Yes, you have to ask about everything in diabetes. You have to ask, what is the last hemoglobin A1C of the diabetes? Is it controlled or not controlled? What medications you are on? You should ask about complications of diabetes. Complications in the eye, did you check your eye yearly? You have any visual problem? Then ask about the kidneys. Do you have any frothy urine? She will tell you no. Then ask about any chest pain, because these are side effects of diabetes. You know, diabetes can affect the coronaries. It can cause chest pain, ischemic episodes. So you have to ask about complications of diabetes. Did you have any injury at your foot before? You feel that you are unsteady while walking? So you should ask about complications in diabetes, and you should make sure that your patient is following. And then finally, you should ask him about any hypo attacks. Did you feel hunger pains before? Excessive sweating? Did you feel palpitations, racing of your heart beats during these episodes? So you should ask very rapidly. Train yourself with your colleague, and you will ask this very rapidly, and you will be very smooth in it. So you couldn't find hypoglycemia, hypotension, then menopausal flushes, it's a possibility. Okay, but if you ask it here in this situation, in this point, are you using any medications? She will tell you, yes, doctor, I'm using a medication. I cannot remember the name of the medication, but you know, I'm having a restless leg syndrome. My father had it also, and me also having this. So that I'm using this this medication. Then you came to the point. She is using this medication, ropinirole, and ropinirole is causing sweating for one of the medications that can cause sweating. At this point, if you couldn't reach the diagnosis still here, okay, I will go back to my consultant and discuss the things with you. But till now, we have to do some blood tests and some imaging for you. And then again, I will repeat it again. At station 5, at station 2, at station 4, you should, as a physician, ask yourself 2 questions. What are the 2 questions you're asking for yourself, doctors? Any doctor can answer at the end of any station.
Shall I admit this patient?
Yes.
Or not?
What is the next question? Driving. Ask yourself, is it any limitations on driving for this patient or no? Number 2, should I admit this patient or no? Ask yourself these 2 questions. If you will forget, write them down, please, in the paper that you will enter in station 5 or station 2 or station 4. Admission plus driving. You should, because you may be mentally blocked inside the exam station. Okay, so this is the sweating case. I think that we covered most of the causes that cause sweating. Importantly, the malignancy, and importantly, the drugs that can cause sweating. And this was the case, patient with restless leg syndrome using ropinirole, and now she came with excessive sweating. Don't be afraid. The things sometimes not so odd like this, but you know, if you trained yourself on the odd things, you will capture the easy things very rapidly. And if you are mind mapped, everything will come to you very easily, inshallah. Don't worry about station 5. If you are mind mapped well, you will get the station 5 very rapidly. Okay, we will have another case now, doctors, if anyone interested to take it. So it will be also station 5 case. If anyone, doctor, interested, he can send me on the private message.
Sorry, doctor, can I ask one question?
Yes, for sure, doctor, yes.
Yes, doctor, insulin could be differential for this sweating, and factitious insulin use also could be differential.
Yes, excellent. We can add it, yes. So we can add it. Insulinoma is very important. But you know, he asked about the hypo attacks, and the answer was no. But yes, very good. We can add it here. We can add it here to our sweating. It can be with hyper. Yes, insulinoma. Insulinoma. Thank you, doctor, for reminding us. Thank you.
Thank you.
Okay. And if you find insulinoma, and if you find, what will you do, doctor, next? Doctor, if you found insulinoma.
72 first.
Any doctor can answer. If you found insulinoma, what will you do?
We will
72 first.
Men. Excellent, doctor. Excellent. Very excellent. If you found insulinoma, ask about men. If you found acromegaly, ask about men. Diet. Don't forget, please.
Yeah.
If you forget, what are these things? Don't worry. This is this will be either min type 1 or min type 2. Okay, so how to remember, because sometimes we forget, you know, the stress. So make it as a song, BBP, BMP, BBP, BMP. So the min type 1, PPP, pituitary, parathyroid, and pancreatic. Min type 2A, BMP, parathyroid, pheochromocytoma, PBB, PMP, yes, parathyroid, medullary thyroid carcinoma, and pheochromocytoma. So PPP, PMP. Don't forget, if you find hyperparathyroidism, patient came with hypercalcemia, don't forget to ask about men. Patient came with prolactinoma, ask about men. Patient came with acromegaly, ask about men. Patient came with insulinoma, ask about men, because insulinoma is a pancreatic tumor. Patient came with gastrinoma, vibome, okay? So ask about men. Don't forget this, please. Okay, doctor. Any question as regards sweating?
Also, doctor, we can add in drug history of use sulfonylurea or insulin, factitious use.
Yes, for sure. See, here the mind map will not cover 100% of the causes. This is most of the causes. But in the history, in the remaining of the history, you will capture the things. Because, for example, if you ask the patient, are you using any medication? She will tell you, yes, I'm using insulin, or I'm using any other medication. What else you added, Doctora? I don't know if sulfonylurea can do like this or no, but however, in the medication history or in the past history, you will capture the things. You know, the mind map will direct you towards a diagnosis. If you couldn't find the diagnosis, for sure, you will find it down either in the past history or in reviewing of other systems, okay? So yes, we can add here sulfonylurea, we can add exenatide, we can add all the hypoglycemic medications, we can add them here, but we can capture them down from the drug history or the past history. Thank you, doctor, for reminding this. Okay, any other questions or any physician want to add anything for us? We are studying with each other. If any doctor want to add, or should we start the other case? Okay.
Please, doctor, you can remember us min 1 and 2, please, again.
Okay, so min 1 and min 2. Min 1, BBB. Min type 2, BMP. So PPB, pituitary, parathyroid, and pancreas. BMP. So PPP, PMP. The second is P. Yes, doctor, you can hear me, yes? Oh, the voice is okay. So the second is parathyroid, medullary thyroid carcinoma, and pheochromocytoma. So PPP, PMP. Don't forget them. You can ask about them within 20 seconds or within half a minute if you capture the case with insulinoma or any association with min type 1 or min type 2A. Okay. So next case, doctors. Is the doctor interested to take the case?
Can I take the case, Dr. Samia?
Yes, Dr. Samia, for sure. 1 second. Okay. So Mr. Hoff Boulding is a 47-year-old, came with leg ulcer for the last 3 weeks. Please take focused history and examine the patient. You have 2 minutes or 3 minutes to prepare yourself, Dr. Sami.
Yes.
دكتور خالد السلام
Yeah.
عليكم.
وعليكم
دكتور
السلام.
خالد.
Yes, عليكم السلام. Yes.
سمعت في حالات كلينيكال ولا ما فيش بعد اذنك؟
Clinical. We have station 5. Station 5 is an integrated clinical station.
There is no discussion for 1 and 3.
No, we cannot discuss 1 and 3 here. 1 and 3 needs clinical cases in front of you.
Just approach يعني maybe in Irish there is long history, there is long cases, there is 2 history of long history. So maybe يعني jaundice, hepatomegaly like this يعني also.
I don't have experience with MRCP Irish. So I don't know, but you know, we have clinical case, but it should be seen because you know, yeah, to see. But sometimes
Yes,
we can bring cases like this, but as a station 5.
Okay, thank you.
Inshallah.
Okay. Okay, we'll start.
Okay, Dr. Asami, give me half a minute, please. One. Yes, Dr. Asami, go on.
Hello. Hi, good evening. Is this is Dr. Samia, one of the doctors here. Is this Mr. Hoff Balding?
Yes, that's me.
Are you 47 years of age? Just to confirm.
Yes, I am.
Hi, Mr. Hoff Balding. We are here to discuss health issues regarding you, and we are going to examine after that. Is that fine with you?
Yes, doctor, I have no problem. Yes.
Oh. Okay, Mr. Hoff Balding, it seems that you're having some kind of soreness in your leg, in your leg. May I know a little bit more about it? When did it start?
Doctor, it started about 1 month ago.
1 month ago. Okay. Can I see the soreness ulcer?
Yes, for sure, doctor. 1 second, I will share it to you.
Yeah.
1 second, I will share it now. Can you see it now, Dr. Samia?
No, I cannot.
Okay, 1 second. Okay, now doctor, it's on the screen.
Yeah, I can see it now. Oh, yes. It's on which side of leg? Is it on the front of shin or medial or lateral?
No, it's in front. Or you can see it's in
okay.
the front.
Okay, front. Okay. Yeah, I can see the ulcer on your leg. You told me that it's from 1 month. Is it same? How did it start? Did it start suddenly or gradually?
Actually, doctor, it was a red. It started as a red patch, then started to increase more and more, and then started, you know, to have this yellow discoloration inside.
Any kind of itching in that?
Yes, sometimes it's itchy, but not that severe. It's not that severe.
Okay. Any pain in the ulcer?
No, I cannot feel pain sometimes, but it's not that severe.
Okay. Is it for the first time you're having this ulcer, or there is any such history in the past?
Yes, this is the first time I have ulcer like this. I didn't see it before.
Okay. Tell me, any past history of diabetes?
Diabetes? No, doctor, I don't have diabetes.
Okay. Any past history of high blood pressure?
No.
You didn't get hurt in the recent past. No history of trauma, I mean.
Trauma? No, no trauma.
No. Okay. Any fever?
No, doctor. No fever at all.
No changes in appetite?
Appetite? No, I eat well. I don't have problem in my appetite.
Okay. Any changes in weight?
No, not at all.
What about waterworks? Is it waterworks is fine? No frothy urine?
Waterwork is okay. I don't have any problem with my urine.
Any problem with the bowels? Do you have loose motions?
Yes, doctor. Sometimes I have loose motion. Yes.
May I know more about it? Since how long you started with loose stools?
Long period, doctor. Loose motion, long period with me. Maybe 10 years.
Is it associated with blood?
Yes, doctor. I'm having this ulcerative colitis for the last 10 years.
Okay. May I know your medication list?
I'm just using occasionally Miscellaneous, but for now I don't use it. It's well controlled. I don't have any problem with it.
Any history of use of over-the-counter medicines?
No.
I'm sorry to ask you a private question, but we need to ask it to everyone. Any use of illicit drugs?
No, doctor. I don't use any illicit medications.
Okay. I'm going to examine this ulcer. Please keep your leg in front while I might ask you some questions. Please bear with me, okay?
Okay, that's okay.
Okay, I'm examining the ulcer, local examination of ulcer. I'm seeing the margins. There is definite margins. This is not a deep ulcer, it's a superficial ulcer with superficial bleeding areas on it. Okay. Movement of the joint is normal, ankle joint. It's not painful.
No, no pain, doctor.
Okay. I will go to the pulse. Pulse is normal.
Yes, 75.
I would like to check the pallor in eyes. Is it okay? Eyes are fine. No pallor.
Yeah. No pallor.
Okay. I will open your mouth. I will need to see if there are any sores in the mouth.
No mouth sores, doctor.
Okay, I'm going to check abdomen. Are there any scars on the abdomen?
I'm having stoma, doctor. Hello?
Hello?
Yes, I'm having stoma.
Hello?
Yes, doctor, you can hear me?
Hello?
Yes, doctor, you can hear me?
Come again?
I am having stoma.
Hello, doctor?
Yes, doctor. Yes, doctor, you can hear me?
No,
Okay.
it's not. Yeah, now I can hear you.
Okay,
Tell
I'm
me
having
any scars on the abdomen?
I'm having stoma already. Yes, there is a scar, yes.
Already stoma. Okay. Okay, any past surgical history? While I'm examining, I'm asking you. Any
Yes,
past surgical history? You have, there's a stoma, so it seems that you have undergone surgery.
Yes, they did some resection of my colon before because I had a flare of ulcerative colitis, and now I'm using stoma for the last 6 months.
Okay, I'm sorry for that.
1 minute remaining.
Are you smoking?
1 minute
Are you
remaining.
smoking?
Smoking?
Okay. May I know your
occasionally.
Okay. May I know your concern?
I'm concerned about this ulcer, doctor. I'm afraid. I don't know. It is related to my problem or this is a cancer? I don't know.
I highly appreciate your concern, Mr.
Thank you.
I forgot his name. And this looks like it's related to your condition of your gut, what you rightly said as ulcerative colitis. It's one of the problem in the defense mechanism where the defense goes against our body and we tend to produce ulcer on the skin. I will involve a skin specialist and take a nip, who will take a snip test and from this ulcer, and will get back to you in next meeting regarding the test result. Is that fine with you?
Time. Thank you, doctor. Yes. 2 minutes for discussion. What's your differential diagnosis, doctor?
My most probable diagnosis is pyoderma gangrenosum, in view of, as evidenced by his past history of inflammatory bowel disease. The other differentials here can be due to trauma, which I have excluded by not giving the history of trauma. Second is by infection. There's no history of fever and any other symptoms of infection. And other differentials is arterial ulcers, venous ulcers, and neuropathic ulcers. But by history, I have ruled out all three.
Okay. What about travel history? She has any recent travel?
I didn't ask.
Okay, that's okay. So you think that she is having pyoderma gangrenosum, yes? You think that her ulcerative colitis is flaring or what?
I think ulcerative colitis is flaring because he's off the medicine as of now, and probably now the skin.
What are the criteria? What are the criteria? Do you know the name of the criteria that measure the flaring of ulcerative colitis?
Yeah, it is more than 6 motions per 24 hours. When there is tachycardia, anemia, and I think on these 4 are there, more than 6 motions per 24 hours, and weight loss, and then increase like tachycardia and pallor.
Okay, so how will you manage this patient, doctor?
I will frame a multidisciplinary team. I will involve a skin doctor who will take first the swab from the ulcer, and also we can take a snip test from this ulcer. And then usually it's being treated with steroid, topical use of steroids.
Time. Thank you very much. Thank you very much, Dr. Sami. You did a very good job. But, you know, because we are stressed, so sometimes we forget things. When you find an easy case in the exam, don't be so happy, because a disaster may be hidden inside it. Okay. So this patient came with pyoderma gangrenosum. Did you ask her if she is having the same ulcer at any area of her body? You did not.
But I
this is very important.
No, I didn't.
This is very important, because you know they brought a case before in UK, mostly in UK. The patient, yes, he had pyoderma gangrenosum in his leg, and the candidate examined his tummy, and behind or below the stoma there was a small pyoderma gangrenosum, another one. So you have to ask the patient, if you find any ulcer or any skin lesion, generally any skin abnormality, if you find any skin abnormality, ask him, do you have other lesions at any area of your body? He will tell you, yes, doctor, I'm having another one beside the stoma. Okay, so if you missed asking about if he is having another one, so the other one may be missed from you and may be infected and may lead to problems with the patient. Okay. So
yes.
Okay, so this patient came with pyoderma gangrenosum. When you catch a diagnosis, especially if the disease you caught, if the disease is having remissions and exacerbations, you should ask yourself, is it in a flare now or no? For example, if you got a diagnosis of acromegaly, you know acromegaly is a very simple case. But in acromegaly, you have to go in 2 ways. Number one, ask yourself, is the disease active or no? This is
Active.
number one. Number two, is it associated with any other condition? Because you know acromegaly can be associated with men.
Men.
Okay.
Men.
The same.
Yeah.
The
Yes.
same idea works here. Patient came with ulcerative colitis. You should ask yourself two questions. Number one, is it flaring or no? Sorry. Number two, is it associated with any other thing or no? Okay. So this patient came with pyoderma gangrenosum. You have to ask him. Sorry, Dr. Sami, I will just mute you now. Okay. So if the patient came with pyoderma ulcerative colitis, you have to ask him if he is in a flare or no. You should ask him how many motions per day now. The patient told you that he's stopped his mesalazine 1 month ago. So now, or 2 months ago. So now you have to make sure that he is not in a flare now. And this is important because your patient may be having a flare and you didn't ask him about manifestations of flare, and then you told him no need to admit you, and then you pushed him to his home and he had toxic megacolon, and then you lost your patient. So please, doctor, again, I will repeat it again and again. Please, doctor, when you see a patient in station 2 or station 4 or station 5, you as a physician should ask yourself two questions. I will write them again. Admission and driving. You should ask yourself as a physician these two questions, admission and driving. Okay, admission, why you will admit this patient if he is in a flare? How to get it from him? If he is having fever, if he is having fever more than 37.8, or if he is having frequent motion, as you said, more than 6 times, more than or equal to 6 times per day, plus one of the following. It's called true love criteria. If his fever is more than 37.8, if his CRB more than 30, ESR more than 30, and hemoglobin less than 10. If he is having frequent motion, plus one of these things, you have to admit him because he is in a flare now. So when you find the patient suspected of ulcerative colitis, and by the way, it can come as a station 1 case. The patient will come to you with a stoma, okay, or even laparotomy, and one of the differentials is ulcerative colitis. Then the examiner will ask you, will you admit this patient? Tell him, depends on the true love criteria. If he is having fever, frequent motions more than 6 per day, plus one of the following: fever, CRB high, ESR, hemoglobin less than 10, so I need to admit him. Okay, so again, doctor, don't forget, please, in station 2, station 5, station 4, my patient needs admission or no? My patient needs recommendation about driving or no? Very important, very extremely important. So this patient came with pyoderma gangrenosum, and as I told you, there is a hidden concern inside. The patient will not ask you, will you admit me, doctor, or no, because this is your job. You should tell him, I need to admit you. So if he is having frequent motion more than 6, but he does not have fever, tell him, I will measure your fever, I will do some blood tests rapidly today for you to determine if you are having a flare of ulcerative colitis or no. And khalas, finished. The admission issue. Driving doesn't work here. No need to tell him about driving in this situation. Okay? So we'll go now about the mind map about the case of skin ulcers. So if you have a patient, please look at the board, please, doctors. I'm writing now. If you have a patient with a skin ulcer, you have to ask him, as usual, onset, course, duration, associations, what increase, what decrease, effect of treatment, and the date of last attack. Okay? Then ask him, and this is very important, how did it start? And the most important again, any other similar lesions at any area of your body or no? Very important. And it came again before in a station 2, and as I told you, the patient was having another pyoderma gangrenosum behind the stoma. And so if you found the stoma, you have to ask the patient gently, don't worry, I will just check if there is any skin lesions below it or no. Okay? So the first question to your mind map, ask your patient, is it painful ulcer or no? Because the differential diagnosis is different in each condition. If he is having painful ulcer, so you are talking about one of three things. He either having inflamed blood vessel, occluded blood vessel, pyoderma gangrenosum, or acute infection. So these are the causes of painful ulcers. Okay? Inflamed blood vessel, I mean vasculitis. Any vasculitis can lead to painful ulcer. So at this point, you should ask him about any joint rash, any joint pain, any skin rash, any rash in sun exposed areas. Okay. The second is occluded blood vessel. What are the blood vessels that we know? It may be vein, and it may be artery, or it may be lymph vessel. These are the blood vessels. So the blood vessel which is occluded, vein, the patients with chronic venous insufficiency. Patient had DVT for the last 10 years or 5 years, and now he is having ulcer over it. So this is secondary to chronic venous insufficiency. And the chronic venous insufficiency accounts for 70% of the cases of painful ulcers in the lower leg. Okay? Then, the arterial ulcers due to chronic arterial insufficiency. It happens with patients with diabetes, hypertension, dyslipidemia, renal failure, Berger disease, and it came as a case before. Patient is smoker, young age, having Berger disease, and is having an ulcer. Then, if he is having thromboembolic event like atrial fibrillation, or he is having a prosthetic valve, then it's embolizing now, or embolized from before and caused arterial insufficiency. Don't forget sickle cell anemia as a cause of this occluded blood vessel. And if you found a thrombose, if you're suspecting a history of thrombosis, you should ask about the 6 questions of blood clot. What are the 6 questions of blood clot, doctors? You can answer.
PNH, antiphospholipid syndrome, basic disease.
No, doctor, tell me, how will you ask the patient?
Any
Family
previous
history of
history of
blood
clots and family
blood.
history of clots.
Okay.
Then any blood
Miscarriages.
thinning medication.
Okay. Good.
Miscarriage, history of miscarriage.
Okay. What else?
Any painful ulcers in private
Or
parts.
racing of heart. Any
Yes.
racing of heart.
Okay. What else? Okay. So to buy time, number 1, do you have any past history or family history of blood clot or no? Number 2, are you using any oral contraceptive pills? Are you a smoker or no? Number 3, do you have any problem in your heart? Not only racing of heartbeat, do you have any problem in your heart because you may have prosthetic valve or atrial fibrillation? Then ask about EBP. A for antiphospholipid syndrome. Any joint rash, any joint pain, skin rash, previous miscarriage? No. Then ask about basic disease. Any mouth sores, any sores in private areas, any joint pain? No. Then ask about paroxysmal nocturnal hemoglobinuria. Did you notice any change in the color of your urine in the early of the morning? No. And the last B for polycythemia. Did you notice that you are having hypertension, high blood pressure? Did you notice that you are having itching, especially after taking a hot bath or no? So These are the 6 questions of blood clot. You have to ask about them if you suspected that you are having a clot in your case. Okay? So these are the causes of painful ulcer. If the patient is not, if the ulcer is not painful, so at this time you have to, the painless ulcer is more dangerous. Yeah, I mean the causes are more dangerous. So the causes are, it may be neuropathic ulcer, okay, or it may be cancer, or it may be cancer like basal cell carcinoma or squamous cell carcinoma, or it may be severe infection, not only a simple infection, severe infection like TB, like leishmania. Okay, leishmania, by the way, doctors came before as a history station, maybe the last year. It came as a history station, the history case in station 2. Okay, but the scenario was not about ulcer, it was about tummy pain and loose motion because the patient had megacolon and megaesophagus. So the neuropathic ulcers, what are the causes of neuropathic ulcers, doctor? You can answer.
Diabetes.
Yes, diabetes. What else?
Peripheral neuropathy.
Yes, yeah, it's peripheral neuropathy, diabetes. What else?
Syringomyelia.
Syringomyelia, yes, excellent. What else? So we said diabetes, we said syringomyelia. The third one is tabes dorsalis.
Leprosy.
Syphilis, yes?
Syphilis.
Yes. So these are the 3 cases. Yes, syphilis, look, thank you. So see, the cases of painless ulcer is more dangerous. Syphilis, sorry, this is not TB, this is TD, sorry, tabes dorsalis, okay? Tabes dorsalis, I wrote syringomyelia, tabes dorsalis, cancer, TB, leishmania, see, dangerous causes. So your entrance to a case of ulcer will be after analyzing from above onset consideration, blah, blah, blah. How did it start? Do you have any other lesions at any area of your body? No. Okay, then tell me, please. You will ask him these questions while you are checking for the ulcer, because ulcer like a rash. Rash, show me. Ulcer, show me directly. Painful or no? If it is painful, inflamed blood vessel, occluded blood vessel, pyoderma gangrenosum, or acute infection. If it is no, so then it may be neuropathic or cancer or infection. Come to our case here, the pyoderma gangrenosum. Okay, doctor, I will remove my drawing for this one. Okay, if you want to take a screen capture before I remove it, if you want. Okay, then we will come to pyoderma gangrenosum. Here, very important to ask about TB, very important to ask about diabetes, and very important to ask about travel history. Very important, because this patient may have leishmania, for example, as we said. Come to the examination. If you found an ulcer in your case, doctor, and even if you got the diagnosis, you should comment on the ulcer. And this is the silly thing in station 5. You have to comment on anything you saw. And we said in the rash lecture, I will, inshallah, I will upload it tonight. Sorry for being late. I will upload it on YouTube tonight, and we'll post the link on our group in WhatsApp. So if you came to an ulcer, you have to examine the ulcer. How to examine the ulcer? Side, size. So side, size. Okay, sides here, I mean the edges, the color of the edges. Then surface. Surface equals the floor of the ulcer. Is it covered? Is it red, containing pus, or no? Then skin around it. The skin around it. Is it red, inflamed, or what? Last thing is oozing. If the pus, if it is oozing or no. So this is how to comment on the ulcer. So if we brought our ulcer, I will not share it again because it will remove these things. So if we commented on it, so we will say that this patient is having an ulcer on the lower right, on the lower, in here, right lower limb. It's about 7 centimeters in diameter, oval in shape. Here, its surface is containing, its surface is red and the margins are well demarcated and red as well. It's not oozing, by the way. Okay, so you have to comment on ulcer by this way. Again, doctor, central to your ability, remember this, central to your ability to manage the dermatology is to describe the rash or ulcer. If you didn't describe the rash or ulcer, he will deduct from you for sure. Okay, then after examining this ulcer, you should have examined the lymph nodes. If this patient is having a TB or having basal or squamous cell carcinoma and some metastasis happen, you have to check for the lymph node or even to offer to check the lymph nodes. Importantly, the related lymph node. So for example, if you find an ulcer on the lower limb, ask him, sir, I'd like to check for the inguinal lymph nodes. He will tell you no need, because you will not examine the inguinal lymph nodes. Okay? So it's very important to examine the lymph node in this case. Also, offer to examine the joints. And finally, offer to do full neurological assessment. So tell him, doctor, sir, I'd like to examine the lymph nodes of this patient. He will tell you, no need. I'd like to check, I'd like to do full neurological assessment if you are suspecting a neuropathic ulcer, because syringomyelia comes with neurological symptoms. Tapered cells come with neurological symptoms. Patients with diabetes comes with neurological symptoms. So you have to offer full neurological assessment for him. Come to the investigations. What investigations you will do for the ulcer of the patient? Any doctor can answer.
Culture swab. We can take a swab from this, or we can do the snip test, biopsy.
Okay, what else?
First, we'll do the basic test.
Basic
CBC.
test, yes, doctor, yes.
Pressure index.
Yes, it's one. So our investigations will be guided mainly. Our investigations will be guided mainly by the history of the history and some of the clinical findings. But for sure,
we'll do venous Doppler and arterial Doppler also.
Yes, very excellent, doctor. Because we will depend on the history mainly. So you have to do basic blood tests for him. Sorry, not blood. Basic tests for him: CBC, basic coagulation, renal function, kidney function, and then ESR. This is an ulcer, doctor, and CRP. This is very important. ESR and CRP may be infected. Okay. We may need to take swab from this ulcer, biopsy. This is for the ulcer. See, doctor, these are basic screens. Okay. Then for the ulcer, or for inflammation of the ulcer, and then for the disease. Don't say investigations randomly, doctor. You are doing the investigations in the basis or generally in your life. Basic investigations for the complaint, and investigations for the etiology, and investigations for the complication. This is how you investigate in your life. If you look at your life in the clinic, you will find yourself doing like this. I investigate basic screens. I investigate for the finding that I found. I investigate for the etiology of this finding and the complication. For example, this patient is having ulcerative colitis. So, but he is having an ulcer. So I will do investigations for basic screens. Number one, CBC, coagulation, renal function, kidney function. This is basic screen. Then investigations for the ulcer itself, which is a swab and biopsy if need. Then investigations of the etiology. This patient is having Crohn's disease. I'm not sure, sorry, or ulcerative colitis. I'm not sure if he needs sigmoidoscopy again or no. Okay, then investigation for the complication. This ulcer may be infected now, so I need to do ESR for him and CRB and search for other complications of the disease. So this is the way how to investigate. Investigate basic investigations, investigation of the finding, investigations of the etiology, and investigations of the complications. Do it systematically like this, and you will not forget anything, inshallah. So you can add, if you are suspecting a venous ulcer, you can do venous Doppler. If you are suspecting this arterial ulcer, you can do ankle brachial index. And if you are suspecting a peripheral arterial disease, still you should to do angiography for this patient. So it's easy, but you have to systematize yourself. Don't say investigations like this, because you know at the end of the station, the stress comes more and more. So don't forget. Even if you forget till the examiner said, I will do basic screens for him. I need to investigate for the etiology and for the complications. Even if you forgot what is the etiology and what is the complication, you will give yourself some time, and then he will ask you what is the etiology, what are the investigations of the etiology. Okay, so this is the way. Last thing to comment on this case, patient came to you with ulcerative colitis or Crohn's disease. You have to ask about the extra-intestinal manifestations. Yes, doctor, this patient came with bioderma gangrenosum. Okay, and bioderma gangrenosum, one of the extra-intestinal manifestations of inflammatory bowel disease. So if he's having one extra-intestinal manifestations, do you think that he is not having another extra-intestinal manifestation? For sure, he may be having. So what are the manifestations of the extra-intestinal manifestations of inflammatory bowel disease? It's a very common mnemonic, a PSAC. What's the PSAC, doctors? You can answer. Any doctor can answer. E for what?
Arthritis.
Aphthous ulcers.
Yes.
Aphthous ulcers.
Ulcer, yes. Aphthous ulcer, yes. What? And the B for what?
Pyoderma gangrenosum.
Bioderma gangrenosum. I for?
Iritis.
Iritis. Okay. E for what?
Erythema nodosum.
Nodosum. S for?
Nodosum.
Sclerosing.
Sacroiliitis.
Sclerosing cholangitis.
Cholangitis.
A for arthritis or anterior uveitis, and C for clubbing. So you should have asked him very rapidly about this thing. Do you have any mouth sores? No. Do you have any problem in your vision? No. Do you have any joints pain? No. Any tummy pain? No. Excellent. And you get it. And you get it. You ask it about the extra-intestinal manifestations very rapidly within 5 seconds. Do you have any mouth sores? Do you have any problem in your vision? Sorry?
What's the abbreviation?
A PSAC, A-P-I-E, SAC, S-E-C. This is abbreviation for the extra-intestinal manifestations of bioderma gangrenosum. You will not be fluent in asking about these questions, doctor, only by lectures or only by courses, even online courses or clinical course. You have to practice with your friend. You have to practice with your colleague. You can make small groups, 1 or 2, to discuss the cases with each other, okay? Now, I'm so sorry, we will stop here. I hope that all of us get benefit. Thank you, doctors, for sharing with us today. Any questions before we end?
There is recurrent gallstones also in this inflammatory bowel disease, right?
Recurrent what?
Recurrent gallstones.
I have no idea of if inflammatory bowel disease cause gallstones or no. But for my knowledge, no. I don't know. We can search for it, but I don't know. I don't know if it is having or no.
Excuse me, doctor. This only excuse me. This one in Crohn disease, oxalate stones. بس ما في other stones.
Yes.
I don't know.
Okay. So we can add it.
بس not gallbladder.
So oxalate stone in
Yes.
Crohn's? Incorrect. Okay. Thank you very much, doctors.
Doctor,
Any other question?
Yes.
Any comment?
Yes. Yes, doctor.
Yeah.
If patient already diagnosed ulcerative colitis, I should ask also about colonoscopy in investigation.
You should ask about, yes, you should ask him when the last time you have been investigated by the camera test. You should ask him. Because usually these patients, they are having regular follow-ups by camera testing, by endoscopy.
Okay, thank you.
Okay? Any other questions or concern, doctor? Thank you very much. Tomorrow, inshallah, we will meet, inshallah, at the same time. If I have time, inshallah, I will post in the WhatsApp group and I will upload the things tonight, inshallah. The previous 2 lectures plus this lecture, inshallah. Thank you very much, doctors. Assalamu alaikum.
Thank you, doctor. Thank you, doctor.
Thank you.